Hi everybody, this is Professor McLaughlin and I'm going to be doing your lecture today on a new program called Camtasia. So bear with me because this is the first time I'm using it. But you should be able to hopefully follow along. I'm going to go through the PowerPoint slides and we'll work through this together. And if you have any questions, please look into your textbook. Okay, write down your questions as we go along. Go back to your textbook and read the things that are unclear or that you need a little bit more detail on, because this is an introduction to the hematologic system. I cannot possibly go over everything in your textbook in a single lecture, and certainly you wouldn't be able to retain it. But my goal is to get across the most important concepts to you so that you don't have to go and figure that out yourself, because right now I think that can be a difficult thing to figure out. I'd also like to clarify that there are some extra PowerPoints on your Sakai resources, and they say optional. So those are for you to view if you want more detail. They were PowerPoints that were used in the past, but I believe that they are way too inundated with information on the slides. They would take away from your understanding if we use them today. However, feel free to use them as a resource. They're wonderful. They came from the text. And then also use your textbook and go along with your unit objectives and start filling them in as we go along so that you can prepare, because you do have an exam coming up next week, okay? So that exam is going to cover, that exam is going to be covering all of the cancer topics we talked about and the hematological system. Okay. And if you still have questions, at the very end after tomorrow, which to me is Monday, after you review this, and they're really burning questions, you can't figure out an answer independently or from each other, feel free to put together a collaboration of questions that you can send to me. But I think you guys are gonna get this. Okay. To start, you need to know all of your normal values, as we've done many times in the past, and I think you guys got them down probably by now. But just as a reiteration, yes, there is a variation depending on what lab you use. You're going to see different lab values, but the important thing is that you know generally what the normal range is, so you can figure out something that's extremely abnormal. You need to know the general function if you are explaining, to someone what each of these things listed on the screen do. Okay, so starting with the red blood cells, what's the purpose of having a red blood cell? What does it do in the body? And most of you probably would have answered that they carry oxygen to all of our cells through the bloodstream via hemoglobin, right? Do you remember how many oxygens attach to a hemoglobin? Hopefully you remember 4. That's what saturates it and turns it red. Okay, and so that's how we get the oxygen around. It's very, very important. That's also why the red blood cell is that color, which we'll come back to because we're going to be talking about anemias. And as you know, anemias, people tend to look, especially iron deficiency anemias, they're going to look very pale. So hemoglobin is going to come into play here. What about white blood cells? What are their purpose? So white blood cells we see when they are activated because there's the presence of some type of foreign body or infection of some sort. Not just bacterial, okay, it could be viral, fungal. And then there's platelets. Platelets are also extremely important. As you know, they also need to be in balance. There's a normal range for these guys, and they stop us from bleeding, okay? Coagulation factors go along with your platelets. They're an important part, and we'll kind of discuss those and vitamin K a little later. Bone marrow. Why is bone marrow important? What does bone marrow have to do with all of this? It's basically the environment in which all of those cells that we just talked about are created. They're made in the bone marrow. Okay, lymph nodes, and we're going to talk about those. They're part of the lymph system. Okay, they help screen different things out that we don't want, and that's why we'll have swollen lymph nodes sometimes. The spleen. The spleen is something that you need to do a little bit more research on. Take a look in your book on the importance of it. And what I want you to focus on is the spleen's function in the immune system. So basically the spleen coordinates our immune system response, and it stores certain cells that it uses to help in the immune system response. An interesting fact, however, is what would happen if you had a splenectomy? So you had to have your spleen removed, which, as we all know, that happens with some people. So if that happens, then who coordinates the immune system response? Who takes over that function? Actually, the liver does. The liver takes over. It's just a fun fact. It's kind of interesting. Our body makes up for areas in which we lose certain cells, and that's just another way that happens. Finally, you should understand what a pluripotent cell is. So it's a cell that can basically differentiate into any other type of cell. So if you've heard of like stem cells, there's hematopoietic stem cells. They can basically become any of the red blood cells, the white blood cells, platelets. And they're important because they help with the renewal of new blood cells, okay? Because that's kind of where they all stem from. So you need to know your normal lab values. There is a quick reference available on Sakai if you want to use that one, or you may choose to use a different one. Okay, hope you guys are excited because basically spent some time coming up with a really cool metaphor for you for the hematological system. It's really fun. So first, I want you to imagine you are in a castle. Okay. So what's our first component of the hematological system? So we're going to start off talking about each of the major components, and then we're going to talk about things that go wrong within those components. But first, introduce them. So these are your white knights. Okay, the white knights are your white blood cells. Now just look at this white knight and think about why he would be sent out. Okay, why are they summoned? Okay, there's not as many white knights, right? Because it's really hard to become a knight. There's not as many of them. And you only really see them come when there's a very specific enemy to fight. Okay, that's when they come. And then they come and they do their thing. They eradicate the enemy. And then they kind of go back down and they go hang out and rest for a while. So these guys are very special. There's only 5,000 to 10,000 of them, generally, okay? However, what happens when you're fighting an infection? You're going to see more of them deployed. So they're a huge part of our immune response. Where are they formed, these white blood cells? Hopefully you said the bone marrow. Okay, and the other thing I wanted to mention is that they are very specialized. So, white blood cells is a general category, but we're going to talk about within the category of white blood cells, there's subcategories of different types of white blood cells, and they are going to do different things against different types of enemies. Okay, now if someone is deficient in white blood cells of some kind. That's when we're talking about someone who's immunodeficient. Because what would normally be eradicated from the body, a simple bacteria, a simple virus that could get eradicated pretty easily, if you don't have these guys for whatever reason due to some kind of immunodeficiency disease, such as a cancer of the blood marrow, of the bone marrow, you are not going to be able to fight off very simple organisms like you normally would in a normal functioning immune system. Another thing that wipes it out, and we'll talk about later, is chemotherapy, right? Because chemotherapy actually attacks rapidly forming cells. And of course, in our bone marrow, we have rapidly forming cells because we're constantly producing white blood cells, red blood cells, platelets, okay? So chemo generally is non-specific in that it just attacks rapidly forming cells, which can hit our immune system pretty hard. So the white knights are very important. So what is leukocytosis? Okay. It's important that you start to recognize cytosis, or osis, I guess I should say, and emias, because those are, we're now looking at, suffixes that are going to be important when you're trying to figure out words and disorders within your patients. So leukocytosis is a fancy way of saying an increase in white blood cells. So generally, you're going to have leukocytosis when you have what kinds of conditions? Right, you're probably saying infections. Okay, same thing we were just talking about. Anemia is actually a blood condition, anemia. Leukemia is going to be a blood condition related to what? The leukocytes. The leukocytes are the white blood cells. And we'll talk more about leukemias down the line. But start to break down words and really, really think about it. And take a look at how beautiful this white blood cell is. It's just beautiful. They're amazing. Okay, neutrophils. So here's where we start to get the subcategories I was telling you about. So these are all white knights, but these are very specific white knights, okay, for different things. Neutrophils. What do you remember about neutrophils from last semester? When do you see them? How quickly do you see them? We take a look at this leg. Okay, what's happening with this leg? Definitely looks like some sort of cellulitis, right? So whenever you have an infection, who's going to be the first guy to get there? And hopefully you're saying the neutrophils. They're always the first to arrive at the site of an injury, some sort of inflammation. You got a piece of wood stuck in your leg. Okay, neutrophils are going to come. They make up the largest percentage of the white blood cells. Okay. In terms of the leukemias, we'll get to them a little later. But what is it going to mean when you see increased numbers of neutrophils? So clearly that could mean an inflammation, right? But also it's more specific when you see high numbers of neutrophils to a bacterial infection. So notice I didn't say a viral or fungal, but a bacterial infection. Certain diseases are also inflammatory, and certain malignancies can be inflammatory as well, so certain types of cancers. Now, what would cause neutrophils to drop in number? So certainly certain drugs that are toxic, chemotherapy. Some people are actually born with a congenital deficiency. And then pancytopenia is another cause, and if you don't know what that means, you do have to go look up that one. Okay, because you're going to notice pancytopenia is going to apply to many different types of blood cells. Lymphocytes. Lymphocytes are another subcategory. So they come next. They come after the neutrophils. Neutrophils are the first, they're the fastest, right? Lymphocytes come second, they're a little slower. They still arrive for inflammation, however. However, they are much more specific in high numbers related to viral and fungal infections. Okay, so not so much bacteria, but viral and fungal. You're going to see higher numbers of lymphocytes. They're also elevated in chronic inflammation, so it's something to note. And what I wanted to ask you is, why do lymph nodes enlarge when we have infections? I'm sure all of you have felt probably somewhere on your neck or around your ear, when you have some sort of respiratory thing in the winter, you get these bad lymph nodes and they get really tender. It's because you have rapidly dividing lymphocytes in the lymph fluid, and they're fighting an infection, and there's a lot of them. And so it actually enlarges within that lymph node. And so what are some reasons, again, that you would have decreased numbers of lymphocytes in your body? Why would your patient have that? So we're looking at the same types of things. We're looking at an immunodeficiency disease such as HIV, chemo, drug toxins, and things. Okay, now we're looking at another subcategory. And if you look at this picture, you're probably thinking, oh, this is a picture of a cat because most people are allergic to cats. But actually, this cat is sneezing because it's allergic to humans. I know, pretty ironic. So it's also an adorable picture. So this cat represents Eosinophils. Okay, so these Eosinophils, mast cells, and Basophils. I want to focus more on Eosinophils, however, because they are related to allergies. So these are going to be very high in number when you're having an allergic response, whether it be hay fever or trigger for asthma, okay, or something like that. In addition, you will see high numbers of eosinophils with parasites, parasitic infections specifically. Okay. So those are the main ones that you need to know within white blood cells, within your white knights. So next, let's leave the knights and let's go to your workers. So these are the guys, as you can see this picture of this guy, a worker. These are the guys that work really hard all day, every day. There's lots of them. And they're doing what? What are they doing for your body? So they are literally carrying on them these oxygen molecules. Okay, they're carrying oxygen to your entire body, to every single cell, everything that is keeping you alive and energized so you can look at this PowerPoint, okay, and keeps your eyes working and your ears open, everything. It's because these guys are bringing oxygen right now. They're really hard workers. How long do they tend to live? And this is important because as you're looking and you know that red blood cells are constantly regenerating, constantly new ones going from those pluripotent cells, right? You need to know kind of when they're expected to die and that sort of thing. So 120-day lifespan tends to be around average. Now, when would that lifespan be shortened? You may or may not have made this connection, but their lifespan actually can be shortened if they don't have the appropriate nutrients. So folate deficiencies, B12 deficiencies, those sorts of things are going to cause your red blood cells to die early, okay, because it's an essential nutrient that they need to be formed correctly and to live their life correctly and for the right amount of time. So those deficiencies are going to cause anemias, and we'll get back to that. So this is the most abundant blood cell. So there's more red blood cells than there are of, white blood cells, platelets, okay? Because clearly we need them to carry the essentials to the castle. So what happens, what would you call it if you had too many red blood cells? There's a condition called polycythemia. So think about it. If you have too many red blood cells, what's your blood going to look like? It's going to be really red. It's going to be, what, thick, viscous, right? And what's going to be the danger of having too thick of blood? It's certainly not going to be moving as fast. You also are at an increased risk for stroke and thrombus. So what would be a reason that you would have too many red blood cells? So there's different things, but first you'd have to consider what it is that stimulates the production of red blood cells. You know it's in the bone marrow, but what stimulates it? There's a very specific thing that's produced. And hopefully you said erythropoietin, which is secreted by the kidneys. So if you have too much erythropoietin, and you guys will see them called EPO shots, okay? Sometimes we give epigen sometimes is the other name, commonly used in the hospital, where we're actually giving people erythropoietin to help them produce their cells. But if for some reason you were given too much of it, certainly you could have too many red blood cells. So even though they're great, you don't want to have too many or too little of any of these guys. Okay. Oh, and yes, that is a bear head on his back. Knowing red blood cells, okay, I think you guys kind of got down the hemoglobin-oxygen connection there. Okay, now we said B12, we said folate. What else is missing? What's another major nutrient needed for hemoglobin synthesis? Well, hopefully you said iron. My husband makes fun of me because I say iron in a weird way, but I emphasize the wrong part. But iron, okay? So all of these things, iron deficiency anemia, folate deficiency anemia, B12 deficiency anemia, these are all ones you've heard of, and you're going to start to understand why it is that they cause an anemia. So let's see. Why? If you look on your patient's chart, you're going to see that they have acute renal failure. And subsequently, you're going to look at their labs, and you're going to see they're very anemic. Okay, so what does that mean? Where's the connection there? Why do they have an anemia? Where's the connection with the kidneys? Well, the kidneys actually produce erythropoietin. So if you're having renal failure or your kidneys are injured for some reason, your erythropoietin is probably not going to be happening as well. Therefore, your bone marrow is not going to be getting enough of it. Therefore, you may not be producing enough of your red blood cells. Okay. In terms of hypoxia, I want you to realize that hypoxia, when your body experiences hypoxia, naturally, assuming your kidneys are working, this will stimulate erythropoietin to be released. It's like your body has this loop, right? This mechanism that knows to produce more when you're experiencing hypoxia of some kind. Pretty neat. Pretty neato. Now, what about red blood cells forming in the fetus? Do they form in a different place? You know where red blood cells form in the bone marrow, but what about in a fetus? So they actually form in the spleen. And it's important for you to know the difference, especially, because you guys are learning how to take care of the entire lifespan. So let's talk about iron. Okay, so as we mentioned earlier, there's a couple of essential nutrients that are needed. Now, iron specifically is needed for hemoglobin synthesis. Okay, so if you don't have enough iron, what's going to happen with your red blood cells? They're going to be deficient in hemoglobin, right? Or hemoglobin may not be formed correctly. Therefore, are you still going to have that red color from perfectly saturated hemoglobin? No, you're actually going to have these pale looking cells. Okay, and we'll talk about that a little later. What I'd like to ask you is where do you think the greatest source of iron comes from in our body? So I guarantee some of you are thinking, my diet, I eat a lot of spinach. And some of you are thinking, I have no idea because I don't eat a lot of spinach or, green things. Maybe you're thinking meat. But actually, the greatest source of iron for our body is from dead, aged red blood cells. So you're thinking, well, how does that work? Remember that constantly our red blood cells are dying. After 120 days, new ones are being born. Well, when the old ones die, which is a normal part of our cycle of the cells, we have macrophages that are stored in the spleen and released, okay, that come and take up those, engulf those red blood cells that have died, and we recycle the iron that's in them. Okay, so yes, so dead aged red blood cells are our biggest source. And it goes back to the bone marrow to be used. Erythrocytes are obviously going to have the greatest proportion of total body iron in the body. Okay. Now let's look at our BrickLayers. So if you look at this guy here, he is a hard worker. And what is he doing? So he's patching holes in the castle. He's finding areas that need to be fixed, and he's going to fix them. Okay, these are our platelets. Those are our BrickLayers. They patch the holes in our body. Our body is this castle. Okay, so you're going to see the platelets come when what? When you have some kind of bleed. You scrape your elbow, or you injure yourself somewhere. It's going to plug that site of bleeding. What's important to realize is that they don't work alone. Their partner in crime is the coagulation factors. Okay, and now if you need to review those if you haven't, okay, because those are very, very important. But there's a coagulation cascade, if you remember from last semester. And so all those things must come together to help us stop the bleeding. So what is the definition of thrombocytopenia? When I ask you about that, if I said that on an exam, what would you tell me about that? You would need to know the normal category of platelets, the normal range, and you would know that thrombocytopenia is occurring if platelets drop below 150,000 platelets per cubic millimeter, which is what? A hypocoagulable state, right? So if you have not enough platelets, what are you at really high risk for? And the answer is going to be you're at high risk for bleeding out. Okay, so we worry about this with certain patients that have low platelet. I mean, we have to be very, very aware of this, very, very protective over them in the hospital. Because if we know that they have low platelet counts, and for some reason they're not coming up fast enough, we need to really make sure they don't bang their arm, right? That they don't hit something by accident. Certainly that they don't fall. Because if they fall, that's when we're worried about them bleeding into the brain and not being able to stop the bleed in time. And in that case, if you have a bleed in the brain, not enough blood will get to the brain on the other side and the brain will die. So this is worst case scenario. So it's important that if you see an abnormal platelet count, that you really look into that and you check and see what's going on. Now, on the flip side, what about if somebody is hypercoagulable? So they have too many platelets, perhaps. Where is the risk there? And hopefully you immediately thought of blood clots, because we're thinking hypercoagulable. They're just going to stick together, right, too easily, and we're going to have all these mini clots forming in the body, shooting around, leading to all kinds of bad things like a pulmonary embolism. Okay, it could cause a stroke. It could cause a heart attack, perhaps. It could cause a lot of really bad things. Okay, so now we're going to kind of back up a little bit, review the things we just talked about, and talk about more things that go wrong within them. What do you notice about these pictures? There's some things, think back to your health assessment. There's something that should stand out to you immediately. Now imagine if you could take your two fingers and you can palpate along this guy's behind post-auricular area and then down, okay, along the cervical chain, the superficial, the deep cervical chains. Okay, imagine you're doing that, what you're going to feel by looking at these pictures. This is lymphadenopathy. Okay, this is a condition called sarcoidosis, which is not a disease we're going to talk about right now, but if you ever watched the show House, it's always on their list of differentials, which is really funny. But there's a lot of things that happen in sarcoidosis, but one of the things I want you to realize is they get these enlarged lymph nodes. Again, if you remember, related to lymphocyte production, okay, because our lymph fluid is filtered through these lymph nodes, so they catch things that are going on and they respond. Okay, so that's kind of just a little review, our white blood cells. So now we're going to look at white knight problems. So what is the problem with leukemia? Remember what a leukocyte is. Remember what an anemia is. Okay. So what we're talking about when we say generally leukemia is that there's one cell line in the bone marrow that starts just being produced, a lot of them. So let's say some, leukemia, it's a leukocyte, some white blood cells being produced in high numbers. Now, on one hand, you may think to yourself, oh, well, but, white blood cells are good. So what's the problem with having too many of them? Where is the problem there? What's going to happen to the other blood cells in the bone marrow if you have too many leukocytes just proliferating? Okay, they're actually going to decrease our red blood cells and our platelets. And remember that there's different types of leukocytes. So usually with a leukemia, if there's one type of white blood cell, the other ones also could be decreased, okay? And there's more to that, and I do want you to look at leukemias. I do want you to read about them. They're very important. Do take a look at those, please. Read a little more in your book there. Lymphomas, so if you look at this picture on the slide, what does that look like to you? And if you saw that on an exam, would you be able to recognize what it's related to? So these are sometimes referred to as LIs. They're seen under a microscope, and they're the classic cell found in Hodgkin's lymphoma. They're also known as Reed-Sternberg cells. And it's kind of just interesting, I think, for us to see what different practitioners are looking for under the microscope and in the lab. And then we've got a multiple myeloma. So clearly these are the things I want you to focus on when you're reading and getting a good grasp of these guys. So a multiple myeloma is going to be a proliferation of plasma cells. It tends to occur most commonly in the bone. And they produce these antibodies that don't really have a function, okay? So take a look at those. let's go back to your red blood cells, so your workers. Remember what they do and why it is that we need them. Remember what the kidneys do that affect our bone marrow production and why we see anemia in acute renal patients. And as you consider that, I want you to also log away two different terms, which are Eosinophils and poikilocytosis. Okay, one has to do with the different sizes in red blood cells and different shapes. So what happens if you don't have enough red blood cells? So think about that. You don't have enough red blood cells, meaning what's going on with oxygen in your body? So hopefully you're thinking there's not enough oxygen in the body, and therefore, what's your body going to do to compensate? What do you think you're going to feel like if you don't have enough oxygen going everywhere? You're going to be tired, right? Fatigue, that's a big one. Okay, weak. You're going to be weak. You're going to have weakness. Right? How's it going to feel when you try to breathe? You're not getting enough oxygen everywhere, including to your pulmonary system. You could have shortness of breath. You could have more difficulty breathing. You could feel like you're not able to, maybe get enough air in sometimes. What about your heart? How will your heart compensate you not getting enough oxygen throughout to all your cells? It's going to beat faster, right? It's going to try to make up from the fact that you don't have enough oxygen in those cells by pumping out more blood faster, hoping that will help, right? So these are common things that we will see if you're lacking red blood cells, having decreased production, okay? So again, remember we talked about leukemia, and we said if the leukocytes are proliferating, let's say a relatively undifferentiated leukocyte proliferating, then the red blood cells and the platelets are really going to be kind of knocked down, right? They're not going to have enough space, they're not going to have the nutrients available, and they're not going to be able to form. So that's one way that we can have decreased production of red blood cells. Same thing with the myelomas, bone marrow cancer, okay? The other major thing that we mentioned earlier is having decreased nutrients, decreased materials for the production of red blood cells. So all these magical conditions need to happen at the same time for us to have this beautiful production of red blood cells. So why would you be iron deficient? What are some of the major things that you think of when you think of an iron deficiency? So a big one is blood loss. Just straight up, you're losing blood, which has iron in it. Because remember, that's where we get our largest iron stores, right, is from aged red blood cells. Now, if you are losing red blood cells constantly, you no longer have them available as stores. So you very easily, you can see acute blood loss. You can also see a chronic GI bleed. Okay, so kind of a slow leak from, let's say, an elderly patient that's been on ibuprofen, has an ulcer, and is leaking, something like that. Is there another group of patients that you would see this in that are very specific, quite commonly? Some of you may have said pregnancy. So pregnancy, for other reasons, quite commonly results in a mild iron deficiency anemia. So that's why you'll see a lot of the prenatal vitamins will actually include iron, and that's prophylactic to prevent them from having that. I mean, you certainly don't want to tell someone to take iron unless they've talked to a provider, however, but it's just kind of an FYI. What about B12? Who is going to be at the biggest risk for B12 deficiency? What do you remember about B12? So vegans, okay, because B12 comes mostly from animal products. That's where we get a lot of B12. And B12 also is related to intrinsic factor, which is produced by the parietal cells. So if you have decreased intrinsic factor, you also could have a B12 deficiency. And so why would you have a decreased, going along with that, why would you not have enough parietal cells producing intrinsic factor in your stomach? Who are patients who would have a problem with that? Who would be at a big risk for having this B12 deficiency? So patients that have had a portion of their stomach removed, so gastric bypass, or perhaps some sort of resection because perhaps they had a tumor or some really, really bad infection or something had to be removed. Okay, and then there's folate. And where does folate come from most of the time? So usually your green leafies, that's what you're thinking for folate. So make sure you eat some of those today. Renal failure, I think we already talked enough about that. You understand. So notice in this picture that this patient has a very red, sore tongue. Okay, and this is something that we see with more severe iron deficiency anemia. Remember that hemoglobin, if it's produced correctly and is saturated, it's going to be responsible for that red color and for the full shape of the red blood cell. So if you don't have enough iron available, what's your red blood cell going to look like then? It's going to be very pale. Okay, it's going to be a pale red blood cell, and you're going to see that manifested in your patient. Okay, so you're going to look in their eyes. Okay, and you're going to look in their nail beds. You're going to look in their lips, and you're going to see manifestations of this paleness from this anemia, not having that iron available. It also affects, when you don't have the hemoglobin production appropriate, it affects the size of the cell, the red blood cell, so it's actually going to be smaller. That's why it says microcytic. And if we're looking at labs, we would certainly see a low serum iron content there. Okay, and make sure you understand why the manifestations occur the way that they do. Okay, so if you saw on an exam question, when you're looking for an anemia, what are you looking for? So you're always going to look at hemoglobin hematocrit. Okay, you're always going to look at that initially. Okay, so you should know those normal values and understand what those labs are. We already talked about bleeding causing iron deficiency, but what we didn't mention was menorrhagia. So that occurs during the menstrual cycle. Some women actually bleed more than is healthy for them, and they actually can become iron deficient. What I wanted to mention with this picture is that a lot of people think that you can just replace iron and it's no big deal and then that fixes everything. But from personal experience and from many people that I've talked to, especially women who have lost blood or been pregnant and they need to replace iron, if you don't do a slow release iron, it tends to make you very nauseous. And so that's something just for you to know. Now let's talk about pernicious anemia. So what does pernicious mean in and of itself? What is pernicious? Pernicious means having a harmful effect. I think if you remember that, you're going to remember B12 deficiency. One thing about B12 deficiency anemia is very different from the other deficiency anemias. Something about B12. It's the only deficiency that can lead to neurological symptoms. Okay, so log that away. That's very important. It's the only deficiency that can lead to neurological symptoms. So if your patient is having neurological symptoms and they're anemic, a lot of times, I mean, you think about B12, okay? And of course, there could be other things, but that's what you need to know that's specific. And that is part of why it's called pernicious anemia, because of the neurological symptoms. So do review those. Now this one, is it going to be a different color? Is it going to be pale? No, these red blood cells are going to be normochromic, okay? But they're going to be larger. And they're larger because these red blood cells are actually released into the bloodstream too quickly because they don't have enough B12. They're actually, their DNA synthesis is not accurate and they're being released too quickly. They're also going to die too quickly. So that 120-day lifespan is not taking effect when you've got a B12 deficiency. They're not going to last that long. Okay, and we talked about intrinsic factor, so that kind of gives you a little bit more of a review on that. And the dietary considerations, we mentioned that vegans were at risk. The main places you're going to find B12 in your diet are liver, eggs, dairy, and seafood. I actually had more than one physician tell me that a lot of times our body stores B12. I mean, that most of us, if you aren't vegan, you probably have a few years worth of B12 stored up in your body. So that's just kind of interesting. What do we do for patients that need B12? So you have to treat the underlying disease, the underlying problem, obviously, first. But you also need to replace the B12. And a lot of times we do B12 shots. So you may know someone who's had one done, or maybe you've had it as well. So now we're on to folate deficiency anemia. So again, this is another one of those major nutrients that you need in order for the red blood cell to be formed correctly and for it to live as long, okay? So it's not affecting the hemoglobin, it's not the iron, so they're going to be normochromic. They're also going to be macrocytic. Again, they're being released too quickly. But if I were to ask you, what type of patient, what's their lifestyle going to look like that's going to make them highest risk? It's going to be alcoholics. And it's interesting, and you should certainly, absolutely read into that to understand why this happens. But alcohol does many things to the body, but it decreases your absorption of quite a few vitamins, minerals, nutrients. Okay, it greatly decreases your absorption of folate. Alcohol also damages the stomach cells. And it also can damage your liver because your liver is metabolizing that alcohol. And when it does that, it uses up a lot of your stored vitamins such as B12 and folate. So if you're constantly having to metabolize alcohol, you're constantly going to be using up your B12 and your folate. Another thing about folate deficiency anemia is that, again, it's ineffective DNA synthesis, just like your B12 deficiency. So are these cells going to live as long, these red blood cells? No, they're not. They're going to die prematurely, okay? And that's a big cause of anemia because you think about they're only produced every so often. If they're all dying prematurely, you're going to have a problem. And the other thought I wanted you to consider is alcoholics, if you've ever known an alcoholic, what do you think to an alcoholic if you've known one, and what it is that they ingest throughout a day? And I mean, if you're looking at food and drinks, okay? And quite often, we see in alcoholics that they tend to ingest a lot of alcohol, which replaces their meals. So they're actually not eating a lot of food. I think that's another really big factor to consider. Okay. So now we're going to talk about Polycythemia Vera, which some of you remember earlier in the presentation. So this is red blood cell overproduction. So we can see this as a genetic disorder, okay, and it leads to this very viscous blood. You could see it with chronic lung disease. You could see it with sleep apnea, okay, and carbon monoxide poisoning. Okay, so that, and by that I'm talking about hypoxia and just increased blood viscosity. So what's this patient going to look like to you? If you think about it, if you have too many red blood cells, they're going to look red, right? They're going to look the color of a saturated red blood cell. So you can see this patient's face. Notice how she's kind of got that red splotchy, and you can see it all over her body. Depending on the patient and their manifestations and how their body's responding to this condition, how old they are, and other medications that they're on, different things can be done to treat it. What's a temporary fix? What's something that you can do, just common sense, if you have too many red blood cells? You can actually do multiple treatments of phlebotomy. So you're literally removing red blood cells by drawing blood out from this patient. Okay, that's one thing that can be done. This doesn't cure the disease, the issue. It's a temporary treatment or fix. In some cases, chemotherapy, depending on the cause, chemotherapy may be enough. Some patients get put on blood thinners. So there's lots of different things that can be done for a patient. And it's very specific to the underlying issue. Okay, and then let's go back to our BrickLayers. So remember who they were. These are your platelets, right? So the guys that patch your holes in your body. So what would be some reasons that we would not have the right amount of platelets? The things you're going to see in the hospital, mainly, you're going to see malignancies, so different types of cancer, people who have been exposed to a lot of radiation, sometimes secondary to malignancy, certain drugs, and autoimmune diseases. Okay. Now, one way sometimes that we find out that someone does not have enough platelets is because they keep bleeding, or perhaps they bruise really easily and they bruise all the time. Really severe nosebleeds that just won't stop. Blood in the urine, okay, because normally, as you guys know, there should not be evidence of blood in the urine, not even microscopic, right? So if you're having bleeding in your urine, it really needs to be looked at and considered where it's coming from. Why are you bleeding? Bleeding into the joints, okay, that is one way. Sometimes, pain from bleeding into the joints, they find out. Menorrhagia, again, excessive bleeding during the menstrual period. Another thing to mention is that your clotting factors, okay, are synthesized in your liver. And remember, clotting factors are, or coagulation factors, they're all part of that coagulation cascade. And you need vitamin K for synthesis, okay, of the clotting factors. Therefore, what's going to happen if you don't have enough vitamin K? If you know that that is so important for the synthesis of clotting factors, what's going to happen if you don't have vitamin K? And you can't produce platelets. So this, the same thing is going to happen. You're going to be at a very high risk for bleeding. So with our newborns, our little babies, nowadays what we do is we actually give them all vitamin K shots as soon as they're born, so that we know that their body has what it needs to be able to clot. Now some of you may say, well, are all babies deficient of vitamin K? No, very few are. However, there are some babies that are born and they don't have enough vitamin K. And what has been found is that these babies die because you don't expect them to be vitamin K deficient. Something happens and they bleed out, and it's too late. Okay, it's too late. And so now they give vitamin K shots to all babies unless the parents refuse them, because there's really no harm in it. It's actually just giving them a boost if they, are fine. And if they were deficient, you're saving their life. So that's kind of just a little bit for you to think about. And just to go back for a second, I just want to make sure you do review kind of the connection between coagulation factors, platelets, and what you're worried about in a hypercoagulative state, which we talked about already. Okay? So make sure that you know all of your normal lab values. Make sure you review your unit objectives. Make sure you understand the major types of anemia that we discussed today and some of the other major terms located in your textbook. Please review Hodgkin's and non-Hodgkin's lymphomas. Please take a look at leukemia as well as multiple myeloma. Okay. And I think that you guys will do very well. If you have any major questions that were not answered and that you cannot figure out from each other from the book, again, please send me an email or perhaps email your SNAP rep and we can go through them. That way there's kind of all the questions are put together. And do that as soon as possible. Otherwise, you guys can always make an appointment to see me in my office or come talk to me at any time. But thank you for joining me on this little experiment here, and I hope you all have a wonderful week, and I'll see you very soon. Okay, remember to deep breathe. Do your deep breathing today. All right, take care.